skin, hair, and nails. These are the objectives. You can read those. All of you know that the skin is the largest organ on your body. It is a very important thing to assess. So basically, when you go into a room to see a patient, the first thing that you're going to do is observe them sitting there. You make all kinds of observations for your assessment. You can see if they're just kind of sitting there, how they're groomed. You're going to see whether they are laying on the table and they seem to be in pain. There's a lot of things that you can observe even without even asking questions and without even thinking about it, really. And the skin is one of those. You're going to be observing their skin for the color, the texture, wrinkles, you know, things like that when you first walk in and you actually meet them. These are the functions of the skin. Remember, you can read those on your own. These are kind of like overview of the skin. One of the things to remember is that it does produce vitamin D, and it also can express emotions, obviously, and regulates temperature. We have sebaceous glands that help on all body surfaces except the palms and the soles of your feet. We also have glands called eccrine glands that are sweat glands and apocrine glands, chiefly in the axillary and groin area that can be stimulated by emotional stress. And these open into hair follicles. And when we get into things like acne, that's where these glands come into play a lot more. The color of the skin depends on 4 pigments: your melanin, the keratin, oxyhemoglobin, and deoxyhemoglobin. So we'll get into some pictures later on of hyperkeratinemia, where people have been in their diet have a lot of high amount of keratin, and that actually affects the pigmentation of their skin. The nails, the purpose of the nail is to protect the distal ends of your fingers. Okay, so it's there for protection. And as you know, there's really, at the very end, there's really no bone. It's more of a cartilage tuft at the end of your fingers. But 1/4 of the nail is covered by that proximal nail fold. The nail grows from the cuticle out, and the nutrition of the body and the skin supplies gives the nail that pink color and the vascularity. One of the things that's important when you're evaluating the nails is that angle. Remember clubbing? So we want to look at that angle. So basically when you put your fingers together here, if you see if this little triangle disappears, there's clubbing involved. And we'll get into that a little bit more later in the lectures. But the angle should be less than 180 degrees when you look at that, when you look at it this way. And there's a picture. This is important when you're thinking about toenails and when people get infections in their toenails and you have to do a toenail removal. How many of you think you'll never do that? I remember the first time I went to clinical down in the Valley in Harlingen as part of my program, and I had never come across this before in my clinicals, but I got down there and my preceptor said, "Oh, great, you're going to get to take your toenail off." And I'm like, "What?" It was horrible. So anyway, I watched him and I said, "Oh, I'm never doing that." Well, famous last story. Then I wound up as the only sole provider in the rural health clinic, and I was like, well, I guess I will. So it's one of those things that, remember that the actual nutrition of the nail comes from the cuticle, and it grows from there out. And when you're removing it, you want to not damage that nail matrix, because then the nail doesn't grow back appropriately. Now, when you're doing an assessment of the skin, hair, and nails, you want to start with some open-ended questions, just like we talked about in our history, right? So we're going to talk about things like, have you noticed any changes in any moles? Or Have you noticed any changes in your skin or colors, or are you having any rashes or anything like that? So some open-ended questions like that rather than closed-in questions. And you basically are examining the skin as you're inspecting the patient. So you're looking at their face, you're looking at their hands and their extremities. As you do the rest of your exam, you're actually assessing their skin also at the same time. Okay? So you don't have to particularly examine the skin first and then go back and do the head and eyes, ears, nose, throat. You're really kind of doing it together as you go through each body system. That saves you time, but it's also important to make sure that you're looking at those things whenever you're examining those parts of the body. So when you look at the scalp, you're going to be looking for plaques in the scalp, loss of hair. You're going to be looking at all of those things when you look at the head. Then you're on the face. You're going to be looking at the skin color and the texture, whether there's bags under the eyes. You're going to be looking for wrinkles. Those can give you clues as to maybe some potential problems that the patient has. The same thing with the color of their skin and whether their nails are healthy, whether they have lines on their nails. You integrate this, as I said. You're going to inspect and palpate the skin. To do a good exam, when you find a lesion, you want to measure it. So it's good to have a ruler handy, which is one of the things that we've asked that you have. But the other thing I would encourage you to do is to measure body parts, so that you always have your hands with you. You may not always have a ruler. So measure the thumb, this first knuckle, measure the tip of your finger, measure your hand, measure to your elbow, because those are things that you can use to actually give you indications of size of lesions. Okay? So oftentimes, this could be like 3 or 4 millimeters. This could be an inch. So those are things that you'll have with you all the time. Okay? You want a pin light to really look at a skin lesion. It's good to look at it under a magnifying glass. So have one handy in your clinic that you can grab and look at, and a good bright light so that you can look at any kind of skin lesions. A wood lamp is always good if you're trying to differentiate types of skin lesions. Some things fluoresce under the wood lamp, like fungal type infections. So those are techniques that you'll use and that you'll learn as we go through. You look for color, you look for symmetry, and you look for pigmentation, loss of pigmentation, and yellowing of the skin, like in jaundice. And we also look at the sclera, because that can actually be the very first indication of jaundice, is a yellowing of the sclera before the skin ever turns that color. History is really important in any system, so we want to also make sure that we include that in our skin assessment. If they have a lesion, when did it occur? What were the changes that occurred? When did it happen? Is there some sort of a sequence? What were the symptoms? Was it associated with any injury or not any injury? Did they just notice it one day? Any other associated symptoms with it? Now, what do I mean by associated symptoms, like with a lesion? Somebody want to give me an example? Itching.
A fever.
If you'd had a fever and then you broke out in a rash.
Trauma.
Dry.
Trauma.
Trauma, yeah. Like if they'd had any trauma. But what about symptoms? Associated symptoms might be
burning, itching, discharge.
Burning, itching, discharge, odor, fever, anything that's associated with that particular onset of a change in the skin. If they've recently been exposed to anything, what might that be? What's a common thing that happens to the skin in response to? Contact dermatitis, sure. What else? What about allergies?
Hives.
Hives, so like medicine. So that's a really important one. Have they recently started taking any kind of new medicine and then broke out in a rash? You know, so you want to ask those kind of questions in your history. Is there any apparent cause? Have they traveled anywhere? You'd be surprised, and I bet Dr. Toon could talk about that, about skin changes and travel. So you go to other countries, there are different things there that you get exposed to, right? All kinds of different skin infections and nematodes and all that kind of stuff. So travel history is important to find out if they've been somewhere that might indicate their diagnosis. And then again, medicine, really important. Here's a picture of the sclera, jaundiced. So you can see that yellow tint to the sclera. And as I said, this guy's skin is even a little bit yellow. But before the skin turns yellow, the sclera will be jaundiced. So always look at the sclera. So I have to tell you the story because when I was in my last semester as a nurse practitioner student, and I was seeing a patient who was young. She was in her 20s. She had just graduated from, or she was in college. No, she was in college, and she had gone to Padre Island for spring break or something. So anyway, she came back and she had vomiting, nausea. You know, I thought she just. So I examined her, and I came back and I told my preceptor I thought she had viral gastroenteritis. You know. He goes in and examines her, and he comes out and says, well, what'd you think about those yellow eyes? I was like, oops, missed that. Turns out she had hepatitis A. So really important. Remember that. Always look at the eyes. Okay. It's first sign. Here we see what I was telling you about before. See the pigmentation on the hand? I think this one has a pointer. But you can see on this particular hand how orange looking it is as opposed to this one. So that's the increased keratin in the skin that can change the pigmentation. So if you didn't do a good history, you might assume that this patient had hepatitis or some sort of liver problem, you know, causing jaundice. So a good history is really important.
So the one on the left is supposed to be more normal?
No.
I mean, excuse me, the right.
Yeah, this one is normal. This one is the keratinemia. Do you have a question about it? Or
Yeah.
Okay. Okay. Cyanosis, you're all familiar with that, I'm sure, as in your nursing. Detecting color changes in light and dark skin. It is different in dark pigmented patients. And so where is the best place to see changes like jaundice in a dark-skinned person? Beside their eyes. Where else? Huh? No. Their palate. Looking at their upper palate will be an indication in dark-skinned people of jaundice. Pallor and cyanosis can be difficult in dark-skinned people, so you need to know where to look for that. Palpating for temperature, moisture, texture, turgor, hygiene, and edema. Remember, I mean, you are all familiar with edema and how to grade edema 1 to 4 plus, pitting edema. Alterations in color that can be, some of them can be normal, but remember your ABCDE pathology. This is something you need to become really familiar with. Skin lesions, you always see ABCDE. So A stands for asymmetry. Okay. B is irregular borders. Borders is the B. C is a change in color. So color is C. D is diameter greater than 6 millimeters. And E is elevation, enlargement. those are like red flags of an abnormal skin lesion. And you would think you would want to evaluate those more. Okay? So if it has asymmetrical, if it's asymmetrical, like a lesion that's growing out one side rather than, growing in the same on both sides. And if it has really irregular looking borders. Like if you think of a mole, you think of how it always looks really round and nice and even all around and symmetrical. That's not anything you worry about. But if you see a lesion that has it's kind of looking like an amorphous type lesion, and it's irregular and asymmetrical, it's gotten bigger over time, that's something to worry about. You can also look at hemangiomas. These are things that people are born with that are vascular markings. Some of those are what they're called stork bites, port wine stains, strawberry marks. Other vascular lesions, telangiectasias. How many of you have actually seen those on patients? Really? No? How many of you take care of patients who might, like internal medicine kind of patients who might have alcoholism or anything? Look at their abdomen next time you do an assessment on them. A lot of times they'll have telangiectasias, or you'll see them on the nose a lot. They're just like little spider veins. And those are typical with certain types of disorders. Spider angiomas, we want to know how to describe the lesions, and we want to know how to differentiate the different types of lesions. A spider angioma, which is like a red spider, they call it, it actually blanches with pressure. So that's one way that you can tell the type of angioma it is. Okay. How many of you seen purpuric lesions? Probably on your elderly clients that have really frail, thin skin, and they have large patches of bruising. That's what we call purpura. Okay. Now you're gonna learn terms that you want to use in your charting. You don't want to say bruising or I can remember going to the clinic one day to do a site visit on a student, and she, in her documentation, put rash. I said, "So that's your diagnosis, rash?" And she's like, "Yeah." I'm like, "No, let's be a little more specific than that. Rash can be lots of things." So we're going to give you the terminology to use, and hopefully you'll learn, how to describe lesions. That's the whole purpose of this, is to help you describe things and know exactly what you're looking at. So petechiae is basically bruising or blood under the skin, but it's a much smaller lesion. So you can see here on the PowerPoint, it's less than 0.5 centimeters in diameter. So petechiae give you a whole different differential diagnosis than purpura, okay? Which is why it's important to describe what it is. So purpura is greater than 0.5 centimeters, and it's confluent. It looks like a big patch of blood under the skin. Hematoma is basically a raised bruise, okay? So there's actually elevation to it, and it's actually palpable. Ecchymosis, on the other hand, is just the blood under the skin or bruising. And you can actually tell the difference between purpura and a bruise, because bruise is due to some sort of trauma to them, and it also involves the connective tissue and underlying, and it will have different stages of resolution. So on a bruise, you'll have, or ecchymosis is the medical term, these stages that it goes through. And you can actually tell how old it is based on the actual color changes that it goes through. So remember to look at that, and then you can kind of tell. This is really important in abuse and things like that, or trauma cases, so that you can tell like when the event really happened, because you may get conflicting information in your history. And in dark-skinned people, recent ecchymosis may look more deep dark purple, but it's difficult to see changes in darker-skinned people on bruises and ecchymosis. So primary lesions and secondary lesions, just so that you differentiate between the two. Primary would be a previously unaltered skin trauma or some sort of process, and secondary may be changes in that primary lesion. Like for instance, if somebody had a fungal infection, and because they were scratching it and all that, it became infected. And so you have a secondary type process going on from an initial primary type lesion. The most important thing whenever you're assessing the skin and trying to describe it is to describe it accurately. So you want to describe it with these terms. You want to describe basically the characteristics of the rash, and we'll go into those specific terms, the location, the distribution, whether there's exudate or not, and what the pattern is, or the arrangement of the actual lesions, and what type of lesion. So what do you think I mean by type of lesion? I'm sorry. Vesicle or nodule or papule or, yeah. So those are the types of words that you use to describe the type of lesion. The characteristics will be things like the color. It's going to be like the shape or the configuration, whether it's elevated, its size, and then the texture. Okay? So these are the characteristics that you're going to describe. So if we were going to describe poison ivy, let's take that example. How would you describe the characteristics of that particular rash in terms of color?
Red.
Erythematous, not red. Erythematous. Okay. Pattern would be, most of the time, if you look at the book, it says it's in a linear distribution, like where the plant or whatever touched you. It's basically wherever that lesion was. It's typically either in linear or confluent type distribution, configuration. And then you describe the size and the texture. So location, you would put where it was on the body, whether it's kind of generalized all over rash or it's localized to a particular area of the body. Now, why would that matter? Whole different pathology, right? So those are really important things. Patterns can tell you a lot. So when somebody's allergic to something, like if they're allergic to metals in jewelry, you'll have a specific distribution or pattern. You know, like you may have a person who comes in and says, I have this rash right here, round rash right here, and I just can't get rid of it. When you start delving into their history, they have a belt buckle that rubs right here, or they have, you know, problem with their ears always getting infected or whatever, they're wearing costume jewelry, or they have a pattern on their hands. They have latex allergy, perhaps. So there's a lot of reasons why the pattern matters, and it will help you in your diagnosis. Remember to review this box in your book, because it'll help you with that. This is on Blackboard, by the way, if you want to put. So exudate. Remember, you describe it in terms of the amount of exudate, odor, color, consistency. Is it yellow? Is it green? Is it thick? Is it thin? Is it white? Is it, you know, cottage cheese-like? Whatever the consistency is, you want to describe that. And then the shape and arrangement. This is pretty important in your diagnosis. So, because the different types of shape and configurations and patterns help us describe different kinds of skin problems. So round or discoid, meaning it's coin-shaped. Annular means that it's kind of circular but has central clearing.
Like ringworm?
Like ringworm. So in the description, it's important to use the right term, okay, so that other people understand what you mean. They should understand what you mean, okay. Grouped in clusters or linear in a line. Confluent means that they all kind of run together, you know, into one big, you know, rash, like hives oftentimes does that. If they're discrete, separate little lesions, zosteriform, there's a word that you need to become familiar with. What does that mean?
Linear along with
It's along the nerve roots. It's along a dermatome. So you'll become familiar with dermatomes. We'll talk about that in neuro. But that's what zosteriform means. It usually means that it follows a nerve root. And so that rash, that gives you an absolute clue as to what's going on in your, you know, what do you think that would be if you described, you know, raised vesicles and a zosteriform pattern? Jingle. Okay. Stellate means it's star-shaped. Reticulate means it's net-like or lacy. Iris or target. Pink macules with purple central papules. And then serpinginous, snake-like or wavy lines. Okay. Some of these you may not use, but you'll use a lot of these in your descriptions. So flat, non-palpable macule is less than 1 centimeter and a patch is greater than 1 centimeter. So these are primary lesions. So you want to know the difference between a macule and a patch. A macule is going to be smaller. They're basically the same. They're flat and they're non-palpable, but one's bigger than the other. Okay, so does that make sense? So palpable, elevated, solid masses, that could either be a papule, which is less than 1 centimeter, a nodule, which is less than 2 centimeters, or a tumor greater than 2 centimeters, or it could be a wheal. How many of you have seen a wheal? TB test is a wheal. Other places that you see wheals are hives. Hives are going to be like confluent wheals on the body. They're irregular in shape most of the time, except for the TB test, because that's kind of a artificial wheal. But they're superficial. They're just areas of localized skin edema, and they're usually transient. That's one of the ways that you can actually diagnose hives, is to ask them, is it, you know, is this basically staying in the same area, or does it kind of come and go and move all over your body? Now that's how allergies or allergic type dermatitis does. If it's a true allergic wheal, it'll get better in one place and then it'll pop up in another. So it kind of moves all over your body.
I think your mic telling you might come off or die because it's not doing anything in the integrity.
Hello? Oh, I guess I have to stay over here. Did you ask Chris about the...
I did. I think there's a class in here in Pleasant. They're using the intercampus thing, and it'll work. He has to turn it off to do it. So he's...
Okay, I'll have to stand here. I'm a walker. It's really hard for me to not move, but I'm going to try, because otherwise you won't be able to hear me on the recording. So I'll try to stay here.
About 5 minutes and see if we get.
Okay. And then, so other type primary lesions, vesicle, bulla, and pustule. Just remember the difference between these. I can guarantee you will see these things again. So make sure that you study this, okay? This is really important that you learn how to describe lesions in a real proper and correct terminology. So vesicles basically are fluid, okay, not pus, but fluid, serous fluid, less than 1 centimeter. And a bullae is going to be more than 1 centimeter, and a pustule is going to be filled with purulent type fluid. So just know the difference. And we'll show some pictures here in a minute. There they are. Macule and patch. So looking at those, you can see examples of macules, freckles, or petechiae. Petechiae are macules because they're not elevated and they're not palpable. A patch, on the other hand, is more than 1 centimeter. An example of that might be a birthmark or a café au lait spot. How many of you have actually seen a café au lait spot? Okay. So those are examples of a patch. And here's a picture. So you've got freckles on the right, my right. Is that your right? Yeah. And then you've got café au lait spots on the left. Papules and plaques, you can look at these on your own probably, and you kind of go through these. But examples of papules are going to be just like moles or elevated nevus, and plaques, which are bigger but elevated, solid, would be like psoriasis plaques. How many of you have actually seen psoriasis plaques? Okay, good. So here's examples, pictures. So here's a dermal nevus, which is just a benign common mole. And you can see here they've got a little ruler here to help them, the size. And then a plaque, which is greater than 1 centimeter. And you can see there's lots of a big plaque of psoriasis there on that person's foot. Here's nodules and tumors. A nodule is going to be palpable and greater than 5 centimeters. And less than 2 centimeters in diameter, deeper and firmer than a papule. So some nodules, examples would be basal cell carcinoma, which is, you can see on this patient here, right here on his nose. That's a basal cell carcinoma, right there. Okay. Fibromas are more benign, and they're not, you can see that if you kind of look at the ABCDE, you see it's elevated, it's irregular, it's asymmetrical, it has a change in color, so it has all of those characteristics of an abnormal type lesion. Fibroma, on the other hand, it's kind of more of a benign condition, and it's just fibrous tissue that's been walled off by the body, and it's going to be a lot more consistent and homogeneous, same color. It's usually white. So just some examples. A tumor is more than 2 centimeters in diameter, also elevated or solid, and much deeper into the dermis. So in other words, some are more superficial, but a tumor is going to be much, deeper into the dermis, and things like a lipoma, where you actually palpate it under the skin, and hemangiomas. So those are examples of nodules and tumors, or tumors, I mean. Here's a picture of a wheal. You can see how it's raised, irregular areas of localized edema, and you would describe this as confluent, where a lot of wheals have kind of come together in one confluent patch. And that is how you would describe it. So that's hives or urticaria, mosquito bite, allergic reactions. Those are examples of wheals. Vesicles and bullae, again, know the difference. Vesicle yet less than 1 centimeter, bullae greater than 1 centimeter. So examples, herpes, chickenpox, shingles, all examples of vesicles, whereas bullae are typically trauma to the skin that is much bigger, serous fluid, where you'd think of big blisters or second-degree burns. So here's an example of chickenpox and of a blister.
So even if the herpes lesions are greater than 1 centimeter, you still call that vesicle?
Well, it depends. You can kind of tell when you look at them, have they just kind of like merged together because there's so many of them, and it looks like lots of little independent vesicles in a patch is different than like one big, bullae.
Okay.
Okay? Does that make
sense?
The same thing with shingles, because they're going to be little, but they may kind of, especially after, several days, it may look like one big blob, but it's really, if you look close, they're more independent little lesions that have kind of just like merged together. And if you had seen it, and that's why sometimes it's hard to make diagnosis, and so you have to rely a lot on your history too, but you may not see it in its initial form. You may see it several days later, or a week later, after they've tried lots of over-the-counter stuff, and they've been putting Gold Bond ointment on it, or whatever. And it does change the appearance. So you have to be a detective and say, what did it look like when it first started? And then kind of go from there. So here's a bullae in a second-degree burn. So you can see that that's a confluent, big area of serous fluid under the skin. So does that kind of help you in your mind with the descriptions? Okay. Pustules, you're probably all familiar with. It has pus in it, basically. Acne, impetigo. So here's a pustule. So you can see that's not a clear fluid. It's yellowish, whitish looking. So that's, pustular fluid rather than clear serous fluid. Then we have secondary type lesions, and that can be from crusting, scaling, secondary infections. It can be from erosion of a vesicle. It can be excoriation from people scratching, ulcers, fissures. All of these are more like secondary type lesions. Scars. So we kind of go through those. A crust is just basically dried residue or blood on the skin. Scales, here's scaly type lesions like dandruff, psoriasis. These are what we call scales, even though the distribution is called a plaque. So scales. Okay. Erosion. So here's an example of the loss of superficial epidermis. So this is typically how you see genital herpes. You don't always see it in the initial state where there's vesicles. You may actually a lot more often see it in this state where the vesicle has ruptured and the dermis has been lost. So this is what we call a secondary lesion or an erosion. Okay? Understand? It is painful. It's extremely painful.
So if it had the vesicle, it would still be primary?
Yeah. If it was still a vesicle.
It's still attacked.
Yes. Excoriation. This is not a great picture, but what that's trying to show you is that people have been scratching on their arms. So you can see like the little scratches here. These are what's called excoriation. Not the best picture in the world. But scratched insect bites and things like that are what we, sometimes psychological, patients with psychological issues have been, like scratching and making skin lesions on their own. So you see a lot of excoriations. Or somebody who had, some other kind of rash that was itching a lot, and so they caused some excoriations. Do you have a question?
On the erosion, if you didn't see the primary vesicle, would you need to say that it appears to be?
No. You can tell that. You can call that an erosion. This top layer of skin has been lost. That's what an erosion is.
But would you refer to a vesicle at all, or just say there's erosion?
No, you say shallow erosion. There's shallow ulcerated, areas of erosion. That's how I would describe it. And you describe where it was, the distribution, the pattern, and all of those other things that we just talked about. Here's an ulcer. Many of you have seen ulcers in the hospital or wherever you may be working as a nurse. So deeper loss of epidermis and dermis. So it's not just superficial, it's deeper. So they've lost, deeper down into the epidermis and dermis. They actually may bleed and scar. So a stasis ulcer or a syphilitic chancre is also called an ulcer. But that's what we call an ulcer. Fissures are just linear cracks in the skin. For example, like athlete's foot is often described as fissures, where you just have deep cracks that have split open in the skin. Scars, you're all familiar with scars. They may be hypertrophic, which is what we call a keloid, okay? Or atrophic, which is basically just very thin and kind of white looking. So here's the pictures. So on your right is a large keloid scar. On the left is some atrophic areas from acne, where they've actually just lost it's kind of thin and white areas of scarring. Lichenification. Lichenification actually occurs with a lot of conditions where there's a lot of scratching and irritation of the skin. And so over time the skin becomes thicker and rough. And you can actually see the lines of skin furrows. So if you look right here, you can see that there's lines through here of the actual skin that are very obvious. This is what we call lichenification. And here's some other pictures. So you can see here, this is most likely like a atopic dermatitis or eczema that people have been scratching a lot, and it's become very thick, and you can see the linear furrows in the skin. Well, that's what we call lichenification.
Do calluses fall in that category or no?
No, that's a whole different, pathology. Lichenification is very much more of an irritation. Calluses are from pressure, and the skin becomes thicker over those bony parts of the body. Vascular lesions, think of spider angiomas and spider veins. So spider angiomas are bright red. They're up to 2 centimeters, really fiery red, and they blanch. They are almost never below the waist. Oftentimes associated with liver disease, vitamin B deficiency, pregnancy, or they can be normal. The older you get, the more of these you have. So, in aging, you'll see some of these things that if you saw them in a young person might be more of an issue than as you get older. They're pretty normal. Spider veins, up to several inches and bluish in color. You've probably seen these, There's no blanching. They're usually on the legs or anterior chest, often due to increased pressure in the superficial veins. So a lot of women have spider veins on their, superficial kind of varicosities on their legs from pregnancy oftentimes. So here's pictures, spider angioma. You can see where it's bright, fiery red. If you kind of pushed on that, it would blanch. And then on the bottom is more of a spider type vein. Cherry angiomas, these are like a mole that's really bright red. And then petechiae and purpura, which we kind of talked about before, they're usually, petechiae is up to 3 millimeters and they don't usually blanch. Purpura, larger, rounded, irregular, confluent patches of erythema and ecchymosis. So ecchymosis is a purplish or reddish blue, fading to green and yellow, indicates blood outside of the vessels. Okay, can be from trauma, can be from bleeding disorders. So here's a cherry angioma. See how bright, fiery red it is? Okay. And here's some purpura. And on the bottom is ecchymosis, or a big bruise. And you can see the different colors in the bottom one. where it's starting to resolve. So you see the smaller pinpoint petechiae over here? If you see, this is what we call petechiae, and then this larger patch is purpura. Make sense? Any questions so far? You still with me? You haven't fallen asleep yet? Okay.
Neither of those blanch petechiae or purpura, or can purpura blanch?
Usually they don't blanch.
Neither.
Neither. Okay. Lesions in healthy older adults that you'll see, the cherry angiomas, like I said, as you age, you're going to see a lot more of those. Seborrheic keratosis, which I'll show you some pictures in a minute, but they look like they just took this little, like, kind of greasy looking lesion and just stuck it on their skin. You've probably seen that in older people, and they have them a lot on their back, oftentimes. So those are what we call seborrheic keratosis. You can differentiate those from actinic keratosis, which can be premalignant, because usually those seborrheic keratosis are going to feel real soft and velvety, and whereas the other kind, like the actinic, are going to be much more rough, and they feel different and they look different. But you just want to make sure you differentiate the two. Okay, these are just some other kinds of lesions that are typical in older adults: cutaneous tags and horns, lentiginous, which people call liver spots, and then purpura, which is basically, in older people, the older you get, the less connective tissue you have, and the skin becomes a lot more friable and thin, so they bruise much easier because of that loss of connective tissue underneath the skin. So any kind of, even just like pressure, like somebody holding their arm really tight, or like my mother-in-law is like in her late 70s and she'll be out, she still works on she has a 40-acre place and takes care of it by herself. But she's out there, you know, working in the yard, and she'll get scratches from the trees or limbs or whatever, and so she's got all these, you know, patches of purpura because of that trauma and the loss of connective tissue. So you see on the left, you can really see it up close. It looks like a big patch that's just been stuck on the skin. That's the seborrheic keratosis, and it has that velvety feel. Okay? I don't expect you guys to know how to diagnose all these yet, because I see some panic look out there. Like, ah! I want you to become familiar with the terms, and you will start to kind of start thinking about differential diagnosis. Like, you want to know how to describe a bullae versus, you know, a vesicle and all that, but you don't have to diagnose a seborrheic keratosis yet. You'll get to that in your management classes, but this is to expose you to those things. So take a deep breath. Okay? And here's a picture of actinic keratosis. So you see the difference. You see that kind of patch-like thing stuck on the skin versus real kind of, looks like rough, and it feels rough. And so you can tell the difference just basically by looking. And you've seen these on older people too. They're like, they call them liver spots or age spots. They're just these kind of brown areas of hyperpigmentation. They're macules because they're not raised. So start to learn your terminology: macules, papules, vesicles, nodules, bullae. Okay? So, the most common cancers in North America are going to be basal cell and squamous cell, and frequently found in people with a lot of sun exposure. So, in our skin assessment as part of our history, We want to make sure that we ask about those things and sun exposure. Do you use sunscreen? Things like that. And make sure that you look at those sun-exposed areas. So in men, the ears, okay, are very important. The nose, the forearms, you know, those are and the neck, back of the neck. And the scalp, if they don't wear a hat. So a lot of times you'll find lesions in the scalp. So when you're doing your exam, you want to look at the head and look at the scalp for any kind of lesions. Malignant melanoma is becoming more common, but it's still relatively rare. 1 in 74 Americans will develop it. It's really associated with more intense burns, so blistering. So in a history in the past of blistering or sunburns in childhood is more conducive to development of melanoma. Okay, so your history is important in that. And also whether they have a family history of melanoma, like a relative, first or second degree relative with melanoma, puts them more at risk. And also if they're light-skinned, Scandinavian heritage, things like that, they're going to be a lot more likely to develop melanoma. Always look at areas that are hidden. You can develop melanoma in the genital area, the vulva. You can also develop it in the nails. And so always look in those hidden areas, okay, of the skin. Picture of basal cell carcinoma. You can see here it's raised and shiny. It has a lot of little telangiectasia. Remember that word? Telangiectasia on the lesion itself. Okay. Squamous cell. How would you describe that? Yeah, it's probably not just superficial. So an erosion, and remember, is superficial. So what's the next one? Ulceration. So it's more of an ulceration. Okay. Oops. Okay, it's not wanting me to go. Okay, and then here, remember your A, B, C, D, E. So tell me, A, you see the asymmetry. B, irregular borders. C, color changes. You see multiple colors in here, okay? D, diameter is greater than 6 millimeters, and elevation. So you've got all of those characteristics here in both of these lesions. Okay? Common abnormalities in children can be cafe LA patches, seborrheic dermatitis, malaria, not malaria, miliaria, which is what? Anybody? Like baby acne. Okay. And impetigo. So these are very common things that you'll see in children. Trichotillomania. How many of you have actually seen patients with that? Do you know what that is? Pulling out their hair, pulling out their eyelashes, pulling out bald areas of the scalp where they pull their hair out. Or there are a lot of teenagers with some emotional issues will have trichotillomania. They're pulling out. And then physical abuse. Talking to your patients about sunscreen is important in terms of health promotion, avoiding unnecessary sun exposure using sunscreen. According to American Association of Pediatrics, they recommend 30, especially for children. Making sure that they examine their skin, looking for lesions in their skin, and that they have an annual exam if they're over 40. I guess this is important because I keep stressing that. You might want to make sure you know this, the ABCDEs for any kind of abnormal skin lesion, but especially for melanoma. Assessment of the nails. We talked a little bit about that. So we want to look at the contour, the shape, and the opacity. We want to look at the degree 160 degrees is normal. Anything greater than that is seen with clubbing, could be chronic heart disease or lung problems. So here's a picture of clubbing. So you can see that angle is different here versus is a normal angle. So that's going to be less than the 160. And then the distorted angle from the clubbing here. See how the nail is curved up and you have some curvature here. So you get this distorted angle of the nail bed. And you can see how their digits even kind of look like sausages on the end almost. They've got the clubbing like. So techniques that you use if you're not sure. I mean, a lot of people you can just look at them and tell. But if you're not sure, you want to do the whole putting the thumbs together or the fingers together and actually looking for that triangle. So you can see the triangle. Put your fingers together. So put your fingers together, your thumbs together. You should see a really nice little triangle there. Okay, between your nails and the knuckles. You see? Okay, so if you don't see that, then you may have clubbing. So if you don't see that nice triangle. So you can see if you put somebody who had clubbing together, their nails are not going to be able to go together because of the clubbing of their finger. Okay, does that make sense? You'll see. You'll see, but see this patient's finger here? So when you put those nails together, they're not going to have that nice little triangle because their nails are not the same shape, and neither is their finger. So you want to look for color, and you test the nail bed to make sure that it adheres to the finger. That's especially important, like if there's trauma or darkness of the nails. Pigmented bands and longitudinal ridging can mean different things, so you want to look for that. You want to look for infection. The term that we use for an infection around the nail is called peritonitis. That's an inflammation of the peritoneum, and the nail folds are red and swollen and tender. And then fungal infections of the nail, the term is onychomycosis. Okay? So that is the medical term for nail fungus. Picture of peritonitis, which is an infection around the nail. And you can see that they've actually got another little area starting here. And they've got this whole thing going on here. And then you've got another word for nail fungus is tinea unguium or onychomycosis. As opposed to onycholysis, which is more of a nail trauma. Okay? So onycho obviously means nail, right? Mycosis is fungus. So if you remember your medical terminology, Latin root thing, that will help you. So here you see the thickening of the nail and the discoloration and the debris underneath the nail bed. Ingrown nails are usually not initially not from an infection, initially from trauma of some sort or some kind of constant irritation. So who typically gets ingrown nails? Runners? Yeah, actually. Or teenage boys a lot of times will come in with ingrown nails because they're wearing shoes that are not the right size. Either they're too big or they're too small, and so their toenail is constantly hitting the end when they're running, or they're in sports and they're playing in sports. You oftentimes get it in middle-aged women who are on their feet a lot and wearing improper shoes, waitresses a lot of times. So it can happen to anyone. It can happen because they got a bad pedicure, okay, and they gouged the edges of the nail and it got infected. It can happen if the person is trying to do their own pedicure and they don't trim their nails properly. What a lot of people do is trim their nails into the corners of the nail bed rather than straight across. And then as the nail starts to try to grow out, because the way the nail is formed is that it actually has a little lip like this. If you were to look at the end of your nail, it isn't just flat stuck on here. It actually has a little underneath that goes under the skin. So as it tries to grow out, if they cut it into the corner here, they don't ever get it completely smooth. And so it's kind of got a little burr there. So as it tries to grow out, it digs into the skin of the end of your nail. And especially if there's any trauma at all, it'll get very inflamed and red and painful. And then it can get infected. So most of the time, it's more of an inflammatory process than it is an infection process unless they let it go too long. Subungual hematomas are basically some sort of trauma that caused bleeding under the nail, and that's the description, the term that you used is subungual, meaning underneath the nail, hematoma. And so it's severe enough that it can actually cause lifting off of the nail bed. And so that can be an emergent problem if they've dropped a dresser on their toe, or they smashed their finger in the door or something and it caused a bleeding underneath the nail and it's turning black and purple and it's really painful and it's kind of lifting up, the nail is lifting up off. So you oftentimes have to release that by drilling a hole in the nail and letting that blood come out. So you basically try to evacuate that bleeding underneath the nail so that you can preserve the actual nail bed. It doesn't get damaged by all the edema. And then you have other things called leukonychiae, or just white spots in the nail plate. Okay. Picture of an ingrown toenail. You can see how inflamed and painful looking that is. Yeah. So this has been going on a little while before this person came in. And remember, never say never, because you may be taking that toenail off for this person to give them some relief. And there's different, and we'll talk about that when you get into your summer diagnostic class. But there's different thoughts about how you deal with ingrown toenails. But most of us just take the whole nail off and let it grow back out completely. You can look at, again, nail dystrophy, like deformity as a result of nail picking or biting. Like a lot of people have nervous habits where they just kind of do this all the time. And that can actually, over time, cause trauma to the nail. It causes like little divots in their nails, as I call it. It's a deformity of the nail. And then onycholysis, which is a loosening of the nail plate with separation that begins at the distal area because of trauma. You can have periungual growths like warts underneath the nail or cysts. And you can have types of nail changes that are associated with skin disease. So you've got spoon nails that can mean anemia oftentimes. We call it colonychiae or spoon nails. You can have Bowes lines. How many of you have seen that? Bowes lines. Are you familiar with that? It's usually after some sort of intense infection or illness, and you'll actually see like there are these deep lines in the nails, and over time they grow out. But you can usually look at them and say, "Oh, were you sick about 3 or 4 months ago?" And they'll go, "How did you know that?" That's they have these deep lines in their nails. Yeah, I'm all-knowing. It's magic. And then white banding or Terry's nails associated with such chronic diseases like cirrhosis, CHF, and diabetes. And then small pits in the nails can actually be an indication of psoriasis. Here's a picture of Koenig-eye and the spoon nails, and that can be associated again with anemia. Warts. Did I go backwards? No. Okay. Hair. Inspect and palpate the hair, as we talked about, and the scalp for the hair loss. You want to describe like diffuse, patchy, male pattern. So become familiar with what is male pattern baldness. What does that mean to you? Receding hairline, or kind of the loss up here in the crown or in the back, one spot in the back. Those are kind of male pattern baldness areas. So if somebody has a little spot over here, that would not be a male pattern baldness, right? That would be another kind of, you would just describe where it was. And what you look for when you're looking at bald spots is it completely devoid of hair, or are there little tiny, broken hairs there? Because that can give you indications whether that's because of some other kind of chronic, problem or a fungal infection. And there's different things that can cause hair loss. So it's important to really examine that. You want to look at the texture of the hair, because fine, really fine hair and loss of hair, kind of sparse, like in patches, can be a sign of hypothyroidism. Okay? Coarse hair can be hypothyroidism in texture, and fine and hyper, but sparse loss of hair can be hypothyroid. Then there's other common abnormalities of the hair, what we call alopecia areata, which is kind of like little patches of hair loss. And that's oftentimes due to stress. You can see this in younger people and teenagers oftentimes, but it's a fairly common thing. It's called alopecia areata. Then you have scarring alopecia and traumatic. Alopecia just means hair loss. Okay, hirsutism. So all of these common things, hirsutism, what does that mean as far as hair abnormalities? Excessive hair in places where you shouldn't see it, in females typically. Okay, and then seborrheic dermatitis. Seborrheic dermatitis is more of kind of a scaly-like plaques in the scalp. Tinea capitis, tinea meaning a fungus of some sort, and capitis meaning on the head, cap. Pediculosis capitis, head lice, and seborrhea. So, let's see. Pictures, there's a picture of alopecia areata. As I said, it's kind of patchy, like androgenic alopecia, like male pattern baldness. Hirsutism, trichotillomania, where they've actually been pulling their hair out in patches, and lesions due to trauma or abuse. Let's just kind of go through here. Okay. Let's look at some of these. So eczema or eczematous dermatitis is really the most common inflammatory skin disorder. You can also have folliculitis, which is an inflammation of the hair follicle. Furuncles are like boils. Cellulitis is an infection that's kind of diffuse. Tinea is a fungal infection that can happen in different parts of the body, and it's called different things depending on where it is. Pityriasis rosea, kind of a self-limiting inflammation of unknown cause, psoriasis, and rosacea. So these are some common skin inflammatory and infectious diseases. They have these in your book, and you can look at these. I'll just show you some pictures. Pictures of acanthosis nigricans. Okay. So what is acanthosis nigricans associated with? Type 2 diabetes, and metabolic syndrome, obesity, prone to type 2 diabetes. Some other things that are like infectious types, so I'll just show you some of these. Smallpox and anthrax. Anthrax on the left, smallpox on the right. These are things that we don't typically see in this country, but if you were to be going to other places, or you just kind of want to know what it looks like. Malignant lesions of the skin, we kind of went over some of these already. Basal cell, squamous cell, malignant melanoma. And let's see. Chickenpox, you've seen probably. Measles. These are things. Okay.